Hi, Perna. How are you? All right. I guess let me.
Good morning, Dr. Paz. I'm good. How are you?
I'm well, thank you. Okay. Okay. Can everybody see the screen there? The talk.
Yes.
Yes. It's in presenter view, Dr. Paz.
It's in presenter view. Oh, here. I see. Yeah, I guess that's because I have two screens. I don't know how to tell. I guess that's okay. You can still see this reasonably well, right? Let me see. Does that help? No, that doesn't help. How about this? That's right. Guys, can you mute your please? No. Can everybody hear me okay?
Yes.
And all right, can you see the screen here?
We see everything.
Say that again. You're not seeing anything?
We see everything. We see what's to come too.
Okay, that's fine. There's not much I'm sorry. I seem to be a little bit. Let me see. If I do this, you still are seeing only the preview slide. Is that right?
Right.
All right. Okay. Well, let's try this and we'll go from there. Okay. So you can see though this smaller panel, right?
Yes.
Okay. All righty. Why don't we start with? Hold on. This is not going to work well. Hold on. Okay. You can see this screen now, right? With it up here.
Yes.
All right. We'll just go with that. Okay. All right. Dr. Barris, since you joined us today, what do you think we're looking at here? This is a 17-year-old who's complaining of palpitations.
So I'm seeing a looks like a change in rhythm from at least in leads 1, and I'm seeing the upright P waves, and then leads AVF. It's a wide complex rhythm. In terms of the rate that we're talking about, when I'm looking at that rate in lead 1, it's more of a rate of about 150, and then we're talking about a rate of more like let's see, closer like 180 when we go to that wide complex tachycardia. That's correct, yes. So what do you think that wide complex tachycardia might be? So it looks like a VTAC to me. That's right. This is ventricular tachycardia. And is there any other clue that tells you this is definitely VT? What's the differential of this? What else could this be? So you could have some sort of SVT with aberrancy. I'm not seeing any signs of like left branch bundle block or anything like that. Now, why do you mention left bundle branch block when you're referring to aberration? Well, immediately I'm not seeing anything in V1 that would tell me more about right branch bundle. But in V6, I do see a little bit of widening, but I'm just not seeing any of the other stigmata. So I think it's a, yeah, go ahead. I'm sorry to interrupt you. I apologize. Oh, yeah, no worries. Yeah, and then otherwise just wide complex. It just looks like a VTAC. Well,
I think that in general, as my dear mentor, Ed Walsh, used to say, wide complex tachycardia is VT until proven otherwise. That's always good advice, and it is VT. And one of the tricks to tell this is VT is to see, so you're right, aberrated SVT can have either a right or a left bundle. So the morphology of the bundle in terms of determining whether it's aberrated SVT or not is not going to be terribly helpful. But one of the things that's a clue here, hold on, just make sure someone's not, one of the clues is that if you look here in lead 2, the rhythm strip, I think you can see that there is ventriculo-atrial dissociation. There appears to be a little inflection on the T wave following every QRS, suggesting one-to-one VA conduction, but on this beat, we do not see that. So this, to me, suggests that there is some element of at least intermittent VA dissociation. Perhaps there's VA Wenckebach, and we're seeing the, maybe, but it's hard to tell. The other thing that's important when you're looking at ventricular tachycardia is the morphology. And as you pointed out, this is actually a left bundle morphology of the VT, an upright wide QRS in V6, downward in V1. Similarly, we see the appropriate morphology in the precordial leads. And just on. So this is a form of VT that we refer to as right ventricular outflow tract VT. And as you would imagine, it means that it's arising from the right ventricular outflow tract or near to the tricuspid valve. This form of VT is usually associated with a structurally normal heart, but it can also be seen in patients who have arrhythmogenic right ventricular cardiomyopathy. So whenever, although this is generally a benign form of tachycardia, when we see it in any patient, we at least need to think about this possible diagnosis. This form of VT represents about 70% of what is referred to as idiopathic VT, meaning we don't know why. And it's probably a form of triggered automaticity. At least that's the belief. Generally, the heart rate's over 100 in it. It usually has a left bundle morphology with a rightward and inferior QRS axis. And VA dissociation may be present, although in young people, AV node may conduct retrograde or antegrade. And so the absence of VA dissociation does not rule out the presence of this arrhythmia. And it can be associated with elevated catechols. And it's important to understand that this form of VT hemodynamically acts much more like SVT than VT. And so it is not uncommon to see a person with RV outflow VT who feels fine or just feels, has a normal blood pressure and is hemodynamically stable. Obviously, just like in SVT, if a patient were stuck in this arrhythmia for too long, this could result in dysfunction and a tachycardia-induced cardiomyopathy. But for right now, generally it's a benign finding. And usually the treatment is either a beta blockade or sometimes ablation. And these types of VT can be challenging to ablate. Let's see here, someone's asking a question in the chat. Yes, okay, I will in a moment. So these can be challenging to ablate, but and one of the reasons they can be challenging to ablate is because oftentimes when a patient is on the cath lab table to ablate it, they don't have very much of the VT. And this is ablated using what we would refer to as an activation map, meaning that we are going to identify the earliest site from which this VT is arising. And it's because it's an automatic arrhythmia, the patient actually needs to have their arrhythmia in order to map it. And sometimes when a patient lies down on the table with sedation or general anesthesia, it can be very challenging to induce this arrhythmia. And so it is also, when you're moving the catheter around, you have to be very careful because when you're touching the endocardium with the catheter in the right ventricular outflow tract, the morphology of your PVCs that are catheter-based will look an awful lot like the actual arrhythmia itself, and so you have to be very careful to be gentle in moving around. One of the things that has helped are algorithms that most of the 3D mapping systems have now which compare the PVC that you're looking at to the clinical PVC and can tell you whether or not it is the same or not. And once one is in the correct location, typically they would do what we refer to as a pace map, where you pace from the direct location that you think the VT is arising from. And theoretically, if you're in the correct location, the morphology of the QRS should look exactly like the clinical arrhythmia. And the standard way is we look at a 15-lead EKG, and we like to see, or 12-lead EKG, see 12 of 12 leads look exactly the same. Today, most of the 3D mapping systems actually will tell you what percentage of the clinical arrhythmia the ECG QRS morphology looks like. And so generally, if it's greater than 95% of the original morphology, according to the algorithm of the computer, that's often a good confirmation that you are in the correct location to perform ablation. But we wouldn't normally pace map exclusively. You would always want to do an activation map and then pace map it as a confirmation. I believe that Dr. Muhammad is asking a question of why it is that the morphology of the QRS seems to be getting a little narrower or wider. It's hard to say. I would say that most of these beats look narrow. I think some of them may be fusion beats with the intrinsic sinus beat, which might be why one or two of the beats may look a little different. I think that'll be my best guess. Okay, this is a patient of Dr. Love, and this is a 49-year-old male who has LTGA VSD with PS, which is unrepaired. Patient is doing well, but is feeling some palpitations. And why don't we go to Perna Bonsall, ask her what she thinks is going on here. I believe you can unmute yourself, Perna.
Yes. Yes, Dr. Pass. So the rate is approximately around 100, I would say. And looking at the rhythm strips starting, it seems like there is a P wave followed by a long PR interval and then a wide complex QRS. And then if I move towards the middle of the strip, it seems like one of the P waves is non-conducted. And then
I should mention that this is a continuous strip, but they are not simultaneous. It's not you probably have already surmised this, but these are not the same strip. Thank you. Sorry to interrupt.
So it doesn't seem like that one conducts. But I don't appreciate the P wave, PR interval constantly increasing and then not conducting. So it's like Mobitz type 2 that you have long PR interval and then you don't conduct and then you restart and then you conduct again.
Okay. What do you make of the QRS morphology?
The QRS morphology is wide, so it doesn't seem like it's the usual conduction through the AV node.
Okay. When you have a wide QRS, so are the P waves conducting mostly though?
Yes, it seems like mostly
Yeah, I agree. So by definition, you are going through the AV node. What do you mean? Why would the QRS be wide? Is it because there's a problem with the AV node necessarily? When we have a problem with the AV node, what is the electrocardiographic demonstration of AV nodal problems?
you might not conduct your P waves. So
It's usually the PR interval, right? It's usually the PR interval that is affected by AV nodal problems. And what does the QRS duration, what does that usually do to?
If there is like a bundle branch block, that would cause the widening of the QRS complex.
Sure, there's some problem with the bundle branches. The His-Purkinje system has some form of disease. So I think if you actually take calipers out, and I guess this is one of the disadvantages of doing a PowerPoint presentation, this PR interval, I do believe, ever so slightly lengthens. But you might be right that this might, if we measured this PR versus this PR, it's possible that they're the same. So if you were going to describe this rhythm, so this is actually from a ZO patch, one of these extended length monitors. How would you describe this rhythm now that if you were going to summarize it? You're writing your report for the ZO, so.
Since you said it seems like it's increasing, so I would write mostly one-to-one conducted beats with increasing PR interval, and then non-conducted PR intervals, P waves. So I would say then Mobitz type 1 heart block.
Okay, what else would you say about the conduction system in this patient?
Yeah, so the wide QRS complexes, I'm not sure what is the conduction pathway based on this ZO patch. Like, I'm not 100% sure, like, where the block happened.
What about on the conducted beats? Are you pleased with this PR interval? Is this a normal PR interval, an abnormal PR interval?
It's prolonged.
So we would normally say something like the baseline rhythm in this patient is first degree heart block with a PR interval of at least 300 milliseconds with evidence for what is probably Mobitz 1 conduction, intermittent Mobitz 1 block or second degree Wenckebach with a wide QRS. So there clearly is evidence for a lot of conduction disease here. Now, does this patient's diagnosis, is this a surprising finding, unsurprising, common, uncommon in a person with LTGA with VSD and PS?
Patients with LTGA are known to have heart block. It's common in them.
That's correct.
So, I mean, it's not unheard.
How is it, actually?
Sorry, your voice broke for me.
I'm sorry, I said, how common is it?
I don't know the exact number, but it's fairly common. That's what I remember everyone telling me.
I think that generally the sort of general rule of thumb is it's about a 1% cumulative risk annually of heart block. So roughly 50% of patients with LTGA by the end of their life will require a pacemaker. So it's very high. And this patient clearly has never had surgery and yet is having this problem. Now it's intermittently happening. And so let's say the patient fainted and you're seeing this intermittently. So what would your recommendation be?
If the patient has fainted, then I think the patient should get a pacemaker. Because
so how would you recommend the pacemaker be placed in this patient with LTGA, VSD, and PS?
Like as in the approach, as in how, sorry.
Technically, would you put a transvenous pacemaker in this patient, an epicardial pacemaker? How would you do that?
I know that you don't like epicardial pacemakers, so.
Well, I don't think that's a fair statement. I think it would be fair to say I like them less than endocardial pacemakers. Why do I like endocardial generally better than epicardial? Is there a reason?
Yes.
Because I want both pacemakers, or is there a better reason?
Because their sensing ability is better than the epicardial pacemakers.
No, it's because that's true of permanent. That's true of temporary wires, but epicardial leads in general have much less longevity versus endocardial leads. So as a general rule, if it is safe and appropriate, we would always prefer an endocardial system because transvenous leads generally are more durable, probably because they're better protected in the endovascular space. They tend to break less commonly. The survival of leads, like a good transvenous system, has like 90 to 95% survival at 10 years after implantation, whereas an epicardial system could be in the 70 to 80% range, significantly less durable. So clearly, we always want a transvenous system, but the answer that I'm looking for is that in someone who has a VSD, we would not typically place a transvenous lead because of the risk of a paradoxical embolism. And so a patient of this nature, this 49-year-old male, would need a epicardial system. And it's for that reason that Dr. Love has been dragging his feet because, as you would imagine, an epicardial system is a big deal. It means he needs a thoracotomy or a sternotomy. And it's a very big operation for anybody, but for a middle-aged person, it's a big deal. So generally speaking, we would, so he's been dragging his feet because he doesn't want to put the patient through this. And in this case, the patient has not fainted. He's just intermittently feeling some palpitations. And this is actually the highest grade block that was observed on a 3-day monitor. And so Barry has decided to continue to monitor him. You know, I think it's clear that he would be better with the pacemaker in terms of not having a risk for a higher grade AV block and fainting, but I think he's balancing that with the dangers and the unpleasantness and the known poor longevity of epicardial leads. So that's the reason. In fact, some people think that epicardial leads are so bad that if an adult is having congenital heart surgery and they end up with heart block, they will not put permanent wires in, even if they know that there's almost no chance of recovery. They would rather that the patient have temporary wires and then go to the cath lab for a transvenous system. That's very common in the adult world when heart surgery is performed in the cases where there's heart block. Okay. Neha Alwalia. This is a 15-year-old who had a VF.
Dr. Pass, Neha's on the phone right now with, I think, P5.
Well, thank you, Grace. Thank you for offering to answer this question. So, Grace, this is a 15-year-old with VF arrest, and this is the ECG following defibrillation. I'm wondering if you would make any observations about this.
Mm-hmm.
That
Okay,
might
so
explain the episode.
it looks like he's back in sinus rhythm.
Yes, he is. And he's very pleased to have gotten out of VF.
It doesn't look like there's a WPW. The PR interval seems normal.
I agree with that. I apologize for the somewhat blurry image, but yes, that's true.
The ST segment in the right-sided precordial leads are abnormal.
Yeah, agree with that statement.
Looks like it's an ST elevation, but it's limited only to that area.
I would agree with that statement. Is there is this pattern suggestive?
Oh, is it Brugada syndrome, Dr. Pass?
Yes, so that very good. So this would be suggestive possible Brugada syndrome. So Brugada syndrome, I'll remind everyone that the ECG characteristics are of a right bundle branch morphology on the QRS, and oftentimes there are ST or T wave elevations, as you correctly pointed out, in leads V1 and V2. It was first described as recently as 1992. Isn't that amazing? There's a disease that's been occurring in human beings for millions of years, and yet it was only described in 1992. And it's more common in Southeast Asia. And in fact, there are all kinds of names for Brugada syndrome before it was identified as Brugada syndrome, like sleeping death and, things of this nature. Just want to make sure. Anyways, it affects males more than females. And I would remind you, it's due to an abnormality in the SCN5A gene, which is the same gene that is implicated in long QT syndrome type 3. It's a sodium channelopathy, but in Brugada, there is inactivation or malfunction of the sodium channel, as opposed to long QT type 3, where there's increased activity of the channel. Don't ask me more about that. I'm not a particular channelopathy expert. The findings can be provoked in the cath lab with procainamide. In countries outside of the U.S., adrenaline is more commonly used. In fact, a lot of experts think procainamide is not a great provocation of the pattern on the ECG, but in the U.S., it's the only agent that is available. And if somebody is having episodes of VF or cardiac arrest, the only treatment that is used at the present time is defibrillator, implantable defibrillator. We know that Brugada patients are more common to have arrhythmias in the setting of fever. So all patients who have Brugada syndrome are advised to aggressively treat any fever. And for patients who have persistent atrial or ventricular arrhythmias, quinidine has been described to be effective. So there are 3 patterns or types of Brugada based on the electrocardiogram type 1, 2, and 3. In type 1 Brugada, which is referred to as the coved type ST elevation, and it has at least a 2 millimeter J-point elevation with a gradually descending ST segment and then eventually a negative T wave. And this pattern, either spontaneously or with procainamide, is considered diagnostic of this disorder. Sadly, this is rarely the case, but if you do see this pattern, it's fairly likely that you do in fact have Brugada. This is the type 2 pattern of Brugada, which is referred to as the saddleback pattern, and you could imagine that the saddle is sort of right here between these 2 bumps in the T wave. So there's at least a 2 millimeter J-point elevation, and then at least 1 millimeter of ST elevation with a positive or a biphasic T wave, which allows for the little saddle, as it were. And unfortunately, though, this can also be seen in healthy subjects. So although very suggestive of the diagnosis, it is not definitive proof of the diagnosis. And in type 3 Brugada, it's coved like type 1, but it could also be saddleback, but the JP elevation is less than 2 millimeters, and there's less than a 1 millimeter ST segment elevation. And so again, type 3 is the most difficult to diagnose because this pattern could be found in normal individuals as well. This is one of the problems with diagnosis of this syndrome. So in this example, I think we would say this is probably like a type 2 with the saddleback pattern. There's at least 2 millimeters of J-point elevation, at least a millimeter of ST elevation with a positive or biphasic T wave. And, again, this pattern could also be seen in healthy subjects. And I have to say that over my career, on a handful of occasions, I have been lucky enough to contact one of the Brugada brothers who have discovered or described Brugada syndrome. There are 3 of them. They're a Spanish family, but only I think one of them is in Europe. There's one in Belgium, one is in Canada, and I think one is in upstate New York. And so I have had the occasion to ask them to look at an EKG and give me their opinion. And on more than one occasion, 2 different brothers named Brugada have given me different opinions regarding the same ECG. So this is a difficult diagnosis to make, just as an FYI. So always something to keep in mind when you're seeing a right bundle with, elevation of the ST segment in the right leads. And this is challenging because a right bundle in the right precordial leads, particularly in V1 and V2, is not considered an abnormal finding in a healthy person. So you have to really look for the J-point elevation and the ST elevation and the abnormality in the T wave to really clinically make this diagnosis. Okay. Why don't we go to Simone Javeri. Good morning, Dr. Javeri. How are you?
Good morning, Dr. Pass. I'm good.
Thank you. Good to hear it. So this is a 12-year-old who has a mitral valve replacement with a backup pacer set at 52 beats per minute. And the question is, what is wrong? And how would you manage this? And before we go forward, David Barris has asked the question, can the baseline ECG change over time? We have a COVID patient demonstrate a Brugada pattern during acute illness that's since resolved. Well, the first thing I would say is I don't think we understand COVID in children terribly well. So is it conceivable that COVID can cause Brugada syndrome? I don't know, but a month ago I would have said that it couldn't cause Kawasaki disease, and we obviously know that's not true. So I think what I would say is, for sure, because COVID infections are associated with high fever, I would definitely say that during the period of active COVID infection, if you had Brugada syndrome, you would need to be very aggressive in treating high fever. And so it would not be shocking to me if a patient who had COVID demonstrate that might bring out the Brugada pattern. And I would say that if I had a patient, at least in 2020 on the 1st of June, if I had a patient who had a Brugada pattern while positive for COVID and febrile, I would suggest to you that that is not from COVID, but that it is just a happy happenstance that the fever brought out the pattern. And so I would be concerned the patient actually does have Brugada syndrome. Is it possible that somehow Brugada syndrome could be temporarily caused by COVID? I think it's highly unlikely since it is actually a channelopathy. So I would say more likely if someone had a pattern during a COVID infection, it's more likely due to fever. Okay, so let's go back to this tracing. Simone, now you've had lots of time to think about it. What do you think is going on?
Oh, sorry. So it looks like in the beginning, the patient is in sinus rhythm. I see 300, 150, 100, about 80 beats per minute for the first 3 beats. And then I think despite the pacer being set at 52, there's a pacing spike that comes earlier than an interval of what you would expect, which captures the V. And then, so I think it's not detecting, it's not sensing the V appropriately. And then on the third pacing spike, there is like an R on T phenomena with VFib, with a decrease in blood pressure and CVP tracings, as you see.
Right, that's correct. So this is an example of undersensing, as you said, of a temporary pacemaker wire, or maybe permanent, I don't know. But clearly, if the rate on the device, if the lower rate limit of a pacemaker has been set at 52 beats per minute, and there's a pacing spike so soon after a sinus beat, this is clearly at a rate that is faster than 52 beats per minute. So this is inappropriate pacing due to undersensing of the underlying rhythm. This happens again in this beat. Again, this is it's pacing at a rate of 150. And actually this R to R is about a rate of 52. So it's clearly not sensing well. And then correctly pointed out, this is a paced beat on a QRS causing VF. And so how would you acutely manage this, Simone?
So acutely, we would need to defibrillate the patient.
That is correct. We would rapidly the patient before Dr. Pastushko came up to the bedside to see what he just did. Yeah. And what do you, and so now you've defibrillated. How much energy would you give to defibrillate this patient, by the way? How many joules per kilo?
2 to 4, 2 joules per kilo.
Right, so two joules is the starting dose for ventricular arrhythmias. This is very important because people tend to make the mistake of thinking it's 1 joule per kilo. For ventricular arrhythmias, it's 2 joules per kilo, not 1, okay? So very, very important. But you're absolutely right. You'd give 2 per kilo, and if that failed, you would give 4 per kilo. And would you synchronize it or do it asynchronously?
This would be asynchronous.
Asynchronous, correct, agreed. Okay, so you've defibrillated the patient, and now you're in sinus rhythm again. What's the first thing you're going to do?
I think if the patient's in sinus rhythm, I would probably detach the pacemaker.
Right, well, certainly the first thing I would do is detach the pacemaker for fear that this would happen again, right? And then how would you test the sensing on this?
So testing the sensing. I haven't done that in a while. So let me
Well,
think.
thank you for going to be an
I would.
doctor in
Sorry?
1 month. I said you're going to be an attending in
Yes,
just 1 month.
Yeah, so for testing the sensing on the wire, so I would want to, let me see, so the sinus rate is about 100. And we want to see if, so we would start off with a higher sensing threshold and see if even on the pacemaker, if you're able to detect the same rate, like if you're getting the, and then I would slowly walk down my sensitivity to see if I'm able to.
Right, so remember that.
Yeah.
That's correct. So the first thing I would say is, because we don't know if this can sense at all, and since this terrible event has occurred, the safest thing to do would be to do a ventricular electrogram, right? You could just take the ventricular wires and put them to one of the leads, like V1, and measure the ventricular electrogram on the ECG paper to see how big it is. That would give you your R wave, and that should tell you what size, how you should set your sensitivity. In other words, if the R wave were, say, 5 millivolts, you would know that you have to set your sensitivity at a sensitivity below 5 millivolts, like at 2 millivolts, in order to properly sense a 5 millivolt electrogram. We don't often do that with ventricular pacing because we assume the ventricular electrogram is very large. And when you turn on a temporary bedside pacemaker, I believe the default on the ventricle sensitivity is 4 millivolts, or 2, it's either 2 or 4. So because the ventricular myocardium is much thicker and larger and creates a much larger signal, it's not uncommon for the pacemaker to sense the QRS at the standard setting that the pacemaker, when you turn it on, has. But there's always a possibility that the surgeon put the wires on the heart, the temporary wires, not very aggressively, and the R wave is small. And in this case, these, assuming these are temporary wires, we're unable to sense the underlying QRS and therefore put this pacing beat in. And this is one of the reasons why I'm not excited about the fact that in our ICU, it's become a standard that everybody's pacing wires are tested for threshold after they come back from the OR. I am fearful that one day something like this could potentially happen, that in the process of testing, it might inappropriately pace. So what you would do is you would set the sensitivity, let's say at 2 millivolts, make it very sensitive, and then you would make it less and less sensitive by raising the value to 3, 4, and 5. And if you look at the top of the pacemaker, you can see whether the device is pacing or sensing. And as soon as you see that the device is pacing in the ventricle, you can assume that it is no longer sensing. And of course, the rate you set on the pacemaker has to be lower than the intrinsic rate. So if you set the device at 50 and the patient is at 100, there should never be pacing, right? Because the sensed rate is always faster than the paced rate. So if you start to see pacing, then you know that that the device is no longer sensing. So what I would do is I would make it increasingly less sensitive, increasing the number from 3 to 4 to 5 to 6 to 7 to 8. And then eventually, as soon as I see one paced beat, which we know it should not be doing, we would know that whatever that number is, that's the sensing threshold. And then I would immediately make it more sensitive so it stops inappropriately pacing. Just the other day, I did this with one of the cardiology fellows in the ICU, and the first paced beat when we were doing that happened to fall at the end of a T wave. Now, thankfully, this did not occur, but it crossed my mind that one day, if one did this enough, it was likely to happen. So it is definitely a concern, and so you should definitely keep your eye on the ECG when you're doing this testing. And it is important to make sure that the sensing is proper on a device, particularly if it is the standard in an ICU to leave the device, a patient attached to a pacemaker, with a backup rate for sensitivity. So very good, Simone. I think you're ready to take care of ICU patients.
Thank you.
So I'll tell Dr. Blaufox that you're ready to be on call on July 1st. Okay, so why don't we go to, I see Uzo is on the line. Uzo, good morning.
Good morning, Dr. Paz.
So what's the pacing modality here?
It's a wide complex, so it's V-paced. And before that, I see a P wave. So I'm sorry.
That I see V thing, and I agree that I see P waves. Right.
So it looks like it's an asensed V-paced modality.
Is that true?
Looking again, it's definitely V-paced.
I agree that in lead 2 there's a P wave before every QRS, but is the PR interval the same?
So no, it seems to lengthen. No, it's not the same. It does lengthen.
Rest of the tracing, do you see a consistent relationship between the P waves and the QRS?
Again, no. So this seems to be, there's no consistent relationship between the P and the QRS. So this patient is in complete heart block. So this is, but this patient is definitely, this is complete heart block. This patient is V-paced. So I would say,
is this a single chamber or a dual chamber device?
so on the P's, I don't see any pacing spikes, or like you said, there's no consistency in the P waves. So I'm sort of tempted to think that this is single chamber pacing.
That's correct. This is a single chamber ventricular pacemaker. That's why the A's and the V's are not really related to one another. So this is a so-called VVI pacemaker in a young patient. And so this patient is in complete heart block and has a VVI pacemaker. And, it's usually at around this age that patients who had chronic pacing, so as often in young people, we'll put in single chamber pacemakers. In the adult world, to put a VVI pacemaker in an adult is often frowned upon because of this syndrome called the pacemaker syndrome, where the absence of AV synchrony causes bounding pulses in the neck, pounding canon A waves, and adults are very uncomfortable with this sensation. Interestingly, though, we virtually never see this in young people who've had chronic heart block and who are paced in the ventricle chronically. And I don't know why that is, except probably two things are happening. One is that they are used to that feeling. And second, they have better function because on average, young people have better heart function than old patients. And so I think the absence of AV synchrony is tolerated better, and perhaps the canon A waves aren't as high because you're end diastolic pressure isn't as high, right? The average 75-year-old may have an ED of 12, whereas the average 17-year-old may have an RVED of 6 or 5. And so probably that's the reason. And so, but by the time a patient is around this age is when we would probably start thinking about upgrading them to a dual chamber device, and we would usually have this type of conversation at this point. I think at this point we're going to stop because we've been at it for 45 minutes. Thank you very much for joining me this week. We'll be back next week again. Hope everybody has a safe week, and thank you again for joining. I'll see everybody at Sinai in 15 minutes at Sinai. Take care, everybody. Bye-bye.